Hi, I'm John Kane. On behalf of CME Outfitters, I'd like to thank you for participating in BriefCase 1 of the four-part CMEO BriefCase series, Treatment Hurdles in Schizophrenia and Bipolar Disorder, applying real-world cases to overcome challenges in real-world management. This edition of the CMEO BriefCase is titled From Bench to Bedside, Applying Clinical Updates to Schizophrenia Management. The goal of this activity is to formulate a treatment plan for individuals with schizophrenia that considers patient preferences, acute versus chronic phases of illness, and the latest evidence on long-term safety and efficacy. We're using a unique platform today that is designed to not only provide you with key strategies to improve the management of schizophrenia, but also opportunities to reflect and dive deeper into those strategies. As you progress through the BriefCase, you will see key points of emphasis along with relevant resources and tools appearing at the bottom of the screen. You may choose to take your own notes by clicking the Add Note button at the bottom right and access those notes on Activity Review page at the conclusion of the BriefCase. You can also access a robust resource library, including articles, guidelines, and practice tools by clicking on the book icon also at the bottom right. So let's begin with our patient, James, a 20-year-old white male student who was brought to the emergency department at 2 a.m. by police after wandering disheveled next to a major highway near the campus where he was attending school. The police were concerned that he had a difficult time explaining what he was doing, and he seemed to make little sense. He did not appear to be intoxicated. His mental status exam in the emergency department revealed a significant thought disorder and paranoid delusions. He had become increasingly concerned that his roommate and English professor were conspiring to have him expelled because he had had sexual fantasies about his roommate. His delusions had become more intense over the past month. In addition, his schoolwork had been deteriorating for several months. He had become increasingly isolated socially. He was admitted to a psychiatric inpatient unit. The presumptive diagnosis was schizophrenia, and he was prescribed an oral antipsychotic medication. After 14 days of treatment, his symptoms improved and he was discharged on day 16. His first appointment in the outpatient clinic occurred 2 days later. His treating psychiatrist scheduled several psychoeducation sessions with James and his family. James' medication experience included sedation and feeling slowed down, with sedation being of most concern to him. As a result, his psychiatrist lowered the dose of his oral antipsychotic and agreed that if sedation persisted, they would try another agent. James expressed some resistance to continued medication on an ongoing basis, but agreed to take medicine for several months and then reevaluate the need. Hi, James. It's nice to meet you. How are you doing?
Hi, Dr. Kane. It's nice to meet you too. I'm doing a lot better than I was a few weeks ago.
Well, that's good to hear. But from the questionnaire that you completed, I see that you still may be having some symptoms that are of concern.
But I'm not as bad as I was. I don't need to go back to the hospital.
James, I don't think that you need to return to the hospital. In fact, I want us to do everything that we can to ensure that another hospitalization doesn't occur. And that starts with a relapse prevention plan. And an important part of that is to ensure that you're continuing to take your medication. And have you been taking your pills every day the way they're prescribed?
Um, okay, I don't always remember to take them. And sometimes I feel like I don't need them, so I don't take them. Besides, when I take them, I'm not as alert as I need to be. I mean, I know that Dr. Stein was very happy that I had to leave school, but I'm not going to let him stop me from coming back.
Who is Dr. Stein?
Dr. Stein's my English professor who tried to get me expelled. Well, it didn't work. I know he called the hospital to tell them to let me know not to come back. He probably called you too, didn't he?
James, I'm concerned that your symptoms have not completely resolved. And in order to prevent another relapse, it's really important for you to continue to take your medication. I mean, let's do this. If you agree to take your medicine, every day as prescribed, and over the next 3 months, your symptoms are really well controlled, then we can revisit your medication plan. And, how does that sound?
Well, I don't want to be on medication for the rest of my life. Pills every day? No, I don't want to live life like that. I'm too young to be worried about taking pills. I'll take them for now, and then we'll see what happens.
So one of our biggest concerns in treating schizophrenia, and particularly in the early phase of illness, where the impact of relapse can be enormous, is to think about the use of long-acting injectable formulation. So we know that rates of non-compliance are high, even within the first year after the very first hospitalization. We know that rates of relapse and hospitalization are unnecessarily high, even after a single episode of schizophrenia. In fact, there was a study done in Finland by Professor Tahonen, in which 2,500 patients who are hospitalized with a diagnosis of schizophrenia for the very first time were followed. And what they showed was that about half of those patients were not taking their medicine within 60 days after leaving the hospital. So this is a considerable risk in patients like James. And I think an opportunity was missed to introduce the possibility of a long-acting formulation even after the very first hospitalization. He was ambivalent about taking medicine, yet he wanted to go back to school. He's in a very high risk category for non-adherence and subsequent relapse and rehospitalization. And relapses at that point can be really detrimental to his opportunities for recovery. So we know that long-acting formulations can help improve rates of compliance and also reduce the risk of relapse. And we're fortunate that we have a number of FDA-approved second-generation long-acting formulations for schizophrenia. And that gives us a variety of medications to choose from, medications that are widely used. And we can start with the oral formulation and make a pretty seamless transition to the long-acting formulation. And we have options, not only in terms of the medication, but also in terms of the injection interval, which can range anywhere from every other week to every 3 months. We also know these medicines well in terms of adverse effects. And we know that the antipsychotic drugs, the second generation drugs, with the exception of clozapine, don't really differ that much in terms of efficacy, but they do differ in terms of adverse effects. So we understand the characteristics of these different medicines. They've all been widely used in their oral formulations, and we can take advantage of that knowledge in switching them to a long-acting injectable formulation. It's also important to understand in patients like James, who've only had one episode, that the risk of relapse doesn't diminish over time. In fact, Professor Tahonen again published another study more recently in which he followed almost 9,000 first episode patients for 8 years and demonstrated that there was not a reduction in the risk of relapse as patients were followed for longer intervals. So I think this is a misconception that many people have. If someone is stable for a year or two following the first episode of psychosis, that then maybe you can discontinue the medicine. That really does not appear to be the case based on long-term data. And we know that long-acting formulations can help improve global functioning. So there have been studies with aripiprazole once monthly in both Canada and Germany, showing improvement in global functioning over time. We've also seen aripiprazole once monthly demonstrating an advantage over paliperidone palmitate in terms of quality of life in a study that lasted for 6 months. It was also interesting that those patients in the younger age group, below the age of 35, were more likely to see that benefit in quality of life. And this gets back to James's situation. I think young people can really benefit from relapse prevention and from using medications that can help improve the quality of life. There have been studies with aripiprazole Lorauxil for acute schizophrenia, as well as studies comparing aripiprazole Lorauxil to paliperidone palmitate, and both medications showed their ability to treat the acute symptoms of schizophrenia and to continue to provide ongoing improvement of those symptoms without any significant increase in adverse events. So in some situations, we could also use long-acting formulations for the acute treatment and then continue the same formulation after the patient leaves the hospital. So the key practice considerations when we think about James's case is to discuss patient preferences and their potential resistance to continued or ongoing medication, to understand that, but to help them establish a relapse prevention plan and to really consider introducing the idea of a long-acting formulation much earlier, even after the very first hospitalization, because we know that those individuals who've had only one hospitalization are at considerable risk for stopping their medication and then for relapsing and experiencing another hospitalization. Let's summarize with our SMART goals: specific, measurable, attainable, relevant, and timely goals. That is what I hope that you will take from this CMEO briefcase to apply to your practice. First, identify long-acting injectables as a tool to reduce relapse and subsequent exacerbations in patients with schizophrenia. Second, incorporate long-acting injectables earlier and more frequently in the acute and long-term management of schizophrenia. And third, weigh the risks and benefits of long-acting injectables to help inform treatment selection. Thank you for joining me today for Briefcase 1 of our 4-part CMEO Briefcase series on treatment hurdles in schizophrenia and bipolar disorder. To view additional briefcases on best practices for identifying patients with schizophrenia who are ideal candidates for long-acting injectables, as well as tips, tools, and techniques to improve the detection of bipolar I disorder and strategies to communicate long-acting injectables as an effective treatment option for bipolar I, please visit www.cmeoutfitters.com. Thank you again for participating, and thank you for providing the best care to your patients.